Okay, now you can hear me. So welcome to this oral session on aplastic anemia and autoimmune disorders. I am Giorgio Rofino from San Raffaele Scientific Institute in Milan, and I'm happy to introduce my co-chair, Florence from Rune, from Paris on the bone marrow transplant in Hôpital Saint-Louis.
Good morning. Sorry. Good morning, everybody. So we will introduce the first speaker, Dr. Fedorenko. We will talk about non-myeloablative autologous stem cell transplant in patients with multiple sclerosis.
Good morning, dear colleagues. Thank you very much for inviting me to be here. It's so nice and to share our experience. And our topic is effectiveness on non-myeloablative stem cell transplantation in multiple sclerosis patients and factors associated with better outcome. First transplantation in Russia was performed in 1999. Since then, more than 2,200 transplantations have been performed in Pirogov Center. The idea, the philosophy of transplantation in our center is to find the best balance between effectiveness and toxicity to improve patients' outcomes, to improve patients' quality of life, and to prevent severe disability. So we aim to evaluate treatment outcomes and prognostic factors in patients with MS undergoing transplantation. So almost 900 patients with different types of MS were included in our study with long-term follow-up. For stem cell mobilization, G-CSF and steroids were used, conditioning regimens including our first variant BEAM-based, 25% of patients, high-dose cyclophosphamide with Rituximab, 62%, and our new protocol, Fludarabine+Cyclophosphamide-based, 13% of patients. Here you can see evolution of our transplantation approach from toxicity to safety and better outcomes with key points of program optimization. And these key points are stem cell mobilization. We started with chemotherapy and stimulations to G-CSF and steroids, conditioning regimen from BEAM and BEAM-based to cyclophosphamide, and finally to Fludarabine and cyclophosphamide-based, monoclonal antibodies from ATG used to Rituximab, and post-transplant care from watch and wait approach to personalized approach to rehabilitation and comprehensive supportive therapy. So this is our new lymphoablative protocol based on high-dose Fludarabine, 154 meter body square, and cyclophosphamide with Rituximab. Our data demonstrated high effectiveness and safety of this program. So toxicity BEAM-based and cyclophosphamide-based program was similar. Fludarabine-based program was much less toxic with less rate of infection, origin toxicity, less duration of cytopenia. TIM in whole sample was 0.67%, all cases in cyclophosphamide-based group, and the main reason was sepsis. Actually, we didn't find any significant differences in event-free survival depending on conditioning regimen, so we calculated other statistic in whole sample. Disability level based on EDSS score improved significantly and as a relapsing remitting as in primary and secondary progressive multiple sclerosis at all time intervals after transplantation to compare with baseline. 5-year event-free survival in entire group was 83.6%, much better in relapsing remitting multiple sclerosis, also almost 19% to compare with secondary and primary progressive variants. The next step, we analyze possible factors associated with effectiveness of transplantation. These factors are age, gender, disability, disease course, disease duration, before transplantation, strategy of AHSCT. This is our approach, early conventional salvage, presence of active lesions, patient-reported outcomes before transplantation, conditioning regimen, ATG use, and previous specific treatment. So after logistic regression, we find that these factors are associated with a less effectiveness of transplantation, age 40 years old and older, progressive variant of MS, previous specific treatment with disease-modified drugs, and conventional salvage transplantation when we perform transplantation in EDSS score 4 and high, and bad baseline quality of life on physical health score based on a SF-36 questionnaire. So, favorable factors associated with success of AHSCT are early transplantation when we do it as soon as possible, remitting variant, treatment-naive group, younger 40-year-old age, and good physical functioning based quality of life assessment. So, 3 risk groups were identified. Low risk group 0-1 factors, 26% of patients, intermediate 2-3 factors, 40% of patients, and high risk group 4-5 factors, 33% of patients. So, and this is our prognostic index. We try to stratify patients in our whole sample, and actually, when I saw it, firstly, it looks like IPI for lymphomas, but actually it works, and you can see that event-free survival in high-risk group was only 58% to compare with 79% in intermediate group and almost 90% in low-risk group. So we found statistical differences between all risk groups. So, and finally, our results demonstrate that transplantation is very effective and safe in patients with multiple sclerosis, and the safest protocol is Fludarabine+Cyclophosphamide with Rituximab, and the vast majority of our patients improved clinically and in quality of life. And what is the most interesting thing, 3 prognostic risk groups were identified with a low, intermediate, and high risk group with very different event-free survival statistics, so 58, 79, and 89%. And the best candidates for AHSCT is patient younger 40 years old with relapsing MS, not having previous treatment with disease-modified drug, and with baseline EDSS score less than 4 and good physical functioning based on quality of life assessment. So, and some experience from our hospital, 3 principles we use in our department to provide the safest and more effective treatment. First one is proper pre-transplant examination, patient selection, and proper preparation to AHSCT. Secondly, proper transplantation approach to provide this treatment as soon as possible, better with the EDSS score less than 4, proper conditioning program, proper supportive therapy during transplantation. And finally, we shouldn't forget about patient after discharge from hospital, proper rehabilitation and supportive therapy, proper treatment outcome assessment, including patient-reported outcomes, quality of life and symptom assessment, and relapse progression prophylaxis. This is lifestyle changing, avoiding unnecessary vaccination, and many other factors. So thank you very much for your attention from all our team. Thank you.
Many thanks, Dr. Fedorenko, for this comprehensive analysis. Is there any question from the audience? Please.
Hello. Thank you, Dr. Fedorenko, for your analysis. It shows that are very consistent with EBMT analysis and also our London data. I have could you explain a little more regarding the previous treatments? We reported that the number of treatments previously undertaken in terms of disease-modifying therapies for multiple sclerosis was a negative adverse factor. Was it also in your case, or was the difference only between treatment-naive and any prior treatment?
We compared 2 groups, treatment-naive patients with very active MS, when we perform transplantation as a first-line treatment, not providing like anti-B cell therapy, Tezabri treatment, immunomodulating therapy, and patients who failed disease-modifying drug, 2, 3, 4 variants of disease-modifying. We found very significant statistical differences between 2 groups. But of course, this is a quite complex approach. Age, disability, progressive versus relapsing are very important. like you saw this in our index. But we use transplantation as a first-line treatment for patients with active, very aggressive MS in the beginning.
Thank you.
Thank you.
Thanks.
Thank you very much.